Arsenic is nearly tasteless, odorless metalloid that causes significant acute and chronic toxicity worldwide. Arsenicals are found in a variety of compounds and industries, and it is continued to be used as a means of homicide and suicide. And chronic arsenic toxicity from unsafe drinking water has the potential to threaten the health of millions worldwide. And it is seen particularly in Bangladesh. Arsenic exists in elemental inorganic salts, organic salts, and gaseous forms. Elemental and organic forms have limited toxicity, whereas inorganic compounds, including arsenide, the trivalent or As plus 3, and arsenide pentavalent, are highly toxic. Arsenite and arsenate are highly toxic. So, arsenic is well absorbed by GI, respiratory, and parenteral routes and may be absorbed through non intact skin. Due to its water solubility, pentavalent arsenic, that is arsenite, is more readily absorbed across the mucous membrane such as GI tract than is trivalent arsenic, that is arsenite, which penetrates the skin more readily due to its increased lipid solubility. Within 24 hours, inorganic arsenic redistribution into kidney, liver, and also lung, GI tract, and muscle and nervous system occurs, and with subsequent integration into hairs, nails, and bone. Elimination from blood is rapid, and excretion is predominantly renal. This is very important. So, the toxicity of the various forms is partly determined by the excretory rates, with more toxic arsenite being excreted at a slower rate than the arsenate or the organic arsenical compounds. Arsenic crosses the placenta and is teratogenic in animals and humans. So, coming to the pathophysiology, it reversibly binds to the sulfhydryl group found in many tissues and enzyme systems. Acute exposure produces dilatation and increased permeability of small blood vessels, resulting in GI mucosal and submucosal inflammation and necrosis, subcerebral edema, and also hemorrhage and myocardial tissue destruction and fatty degeneration of liver and kidneys. Subacute or chronic exposure can cause primary peripheral axonal neuropathy with secondary demyelination. Inhaled arsine Inhaled arsine attaches to the sulfhydryl groups of hemoglobin, producing an acute hemolytic anemia with resulting jaundice, abdominal pain, and hemoglobinuria induced acute renal failure. Coming to the clinical manifestations, the clinical features can be the acute toxicity can be resulting in form of 10 minutes to several hours, and GI symptoms will be nausea, vomiting, and cholera like diarrhea. Cardiovascular will be hypotension, tachycardia, dysrhythmias, including torsade de pointe, and secondary myocardial ischemia. In case of pulmonary, we will see IRDS, and also in case of renal, acute renal failure, and in neurologic, there will be encephalopathy. Subacute toxicity is seen 1 to 3 weeks after acute exposure or with chronic exposure. It is mainly seen with the neurological, cardiovascular, and pulmonary. Neurological, we will find headache, confusion, delirium, and personality changes. Peripheral neurologically, we will find sensory and motor neuropathy. And in cardiovascular, there will be QT prolongation. And in pulmonary, we will find cough, alveolar infiltrates. And in skin, we will find rashes, alopecia, and Meeks lines. In case of chronic toxicity, seen in ongoing low exposure or occupational or environmental exposure. Uh, in the skin, we'll find hyperpigmentation, keratosis, Bowen's disease, squamous and basal cell carcinoma. Cardiovascular manifestation will be in the case of in terms of like hypertension, peripheral artery disease, and in endocrine system we'll find diabetes mellitus, and lung and skin cancer can be as a result of the chronic exposure. So, following injection clinical usually develops within minutes to hours. Severe gastroenteritis with nausea, vomiting, and cholera-like diarrhea is a hallmark of the acute poisoning and may last for days to weeks, frequently necessitating hospitalization. Patient may complain of metallic taste, hypotension, and tachycardia secondary to volume depletion. Capillary leak and myocardial dysfunction occur in moderate to severe cases. ECG may demonstrate non-specific STT changes and T wave changes and with prolonged QT interval. Although these findings are more common in the chronic intoxication, ventricular tachycardia with torsion depont morphology may occur. Acute encephalopathy with and ARDS, acute kidney injury and rhabdomyolysis may ensue. Survivors of the acute toxicity and patients who are poisoned slowly may develop subacute toxicity, typically presenting with weakness, muscle aches, abdominal pain, memory loss, personality changes, and periorbital and extremity edema or skin rashes with a history of gastroenteritis occurring 1 to 6 weeks earlier. So this is mainly subacute, right? So 1 to 6 weeks prior to that, patient will be having uh, the acute gastroenteritis symptoms. Along with this, now currently will be presenting with personality changes, weakness, muscle aches. So central neurological symptoms will be including like uh, like headache, confusion, delirium, and personal changes, which may become chronic, and peripheral neuropathy may be seen. And rarely an ascending paralysis mimicking GBS may be seen, and dermatological manifestations vary, and they may include morbilliform rash, alopecia, and desquamation. Meese lines can be seen. Meese lines are 1 to 2 mm wide, transverse white lines in the nails. Due to disrupted keratinization of the nail matrix, these may be seen in acute toxicity 4 to 6 weeks after an acute exposure. Chronic toxicity from the arsenic occurs with ongoing low level occupational or environmental exposure and has been linked to the development of hypertension, peripheral vascular disease, and diabetes mellitus, epidermoid cancer, respiratory tract cancer, hepatic angiosarcoma, and possibly leukemia. Dermatological manifestations are prominent and include hyperpigmentation, hyperkeratosis of palms and soles, Bowen's disease, and squamous cell and basal cell carcinoma. Perforation of nasal septum has been found in workers exposed occupationally to arsenic. Coming to the diagnosis is easily missed without history of exposure to arsenic, and physicians rarely encounter arsenic toxicity. Consider arsenic poisoning in a patient with hypotension and that was preceded by severe gastroenteritis with no apparent explanation. Chronic arsenic toxicity should be considered in a patient with peripheral neuropathy, skin manifestation, or recurrent bouts of unexplained gastroenteritis. An abdominal radiograph may demonstrate intestinal radiopaque metallic flecks following ingestion. ECG may often reveals a prolonged QT interval especially in subacute poisoning. The CBC may reveal normocytic, normochromic, or megaloblastic anemia or thrombocytopenia. WBC count may be elevated in acute toxicity and decreased in chronic toxicity. Relative eosinophilia and red cell basophilic stipplings may be seen, and elevated reticulocytes are found in cases with the component of hemolytic anemia. Definitive diagnosis of acute poisoning is made by finding arsenic levels in 24 to 48 24-hour urine collection. All urine measurements of metals should be collected in metal-free containers after a 5-day seafood-free diet. There is large amount of organic arsenic in seafood. That's why normal urinary arsenic level is less than 50 micrograms per liter, and total urinary arsenic excretion in an unexposed patient typically does not exceed 100 micrograms per day. So, if the baseline urinary level is within normal levels and arsenic intoxication is still suspected, hair and nail clippings should be harvested for laboratory analysis. Due to rapid distribution of arsenic in tissues, blood arsenic levels are often unreliable. So, include arsenic toxin in differential diagnosis for shock of unknown cause, encephalopathy, peripheral neuropathy, Addison's disease, hyperparathyroidism, patients with previously mentioned dermatological manifestations, Korsakoff disease syndrome, persistent gastroenteritis, and cholera-like diarrhea, porphyria, other metal toxicity such as thallium and mercury, and unexplained prolonged malaise and weakness. Coming to the treatment, acute arsenic toxicity is a life-threatening illness requiring aggressive management. Hypotension and dysrhythmias are most common cause of death. So hypertension, usually due to volume depletion, should be managed initially with a steroid volume replacement and vasopressor support with dopamine or norepinephrine may be required. Avoid overhydration because pulmonary and cerebral edema can occur, and ventricular tachycardia fibrillation may be treated with lidocaine, amiodarone, and electrical defibrillation as necessary. Magnesium sulfate, isoproterenol, and overdrive pacing therapies can be considered for torsa depend. Monitor and correct potassium, calcium, and magnesium levels. Institute gastric lavage with large bore orogastric tube for acute ingestion. Activated charcoal poorly absorbs arsenic but may be effective for co-ingestions. And whole bowel irrigation should be considered if abdominal radiograph reveal intestinal radiopaque material consistent with arsenic. Chelation therapy for arsenic toxicity uses dimercaprol or succimer. Treat patients with acute arsenic poisoning or severe life-threatening with dimercaprol until clinical condition stabilizes, and succimer with the less toxic oral chelating agent can be substituted. And do not delay chelation in severely ill patients until laboratory confirmation, because chelation is most effective when given within minutes to hours of exposure. Conversely, hold chelation in clinically stable patients with suspected chronic arsenic toxicity pending diagnosis. Chelation with the oral agent succimer may lower tissue content of the arsenic and speed urinary excretion, but does not appear to decrease the morbidity or mortality in the chronic arsenic poisoning. Obtain early consultation with a regional poison control center or medical toxicologist for treatment. For chronic toxicity, prevent further arsenic absorption, and, if appropriate, GI decontamination. Dermatologic manifestations of chronic toxicity are unresponsive to chelation. Okay, so in this position, so we will discuss the table. So dimercaprol given in case of arsenic poison patients, dimercaprol 3 to 5 mg per kg deep intramuscular injection every 4th hourly for 2 days, followed by 3 to 5 mg per kg IM every 6 to 12 hourly until able to switch to succimer up to 10 days total. So total days of duration of therapy is 10 days, and succimer 10 milligram per kg per oral every 8 hourly for 5 days, followed by 10 mg per kg per oral every 12th hourly for 14 days. And children less than 5 years old should be given 350 milligrams per meter square per oral on adult schedule. Coming to the discussion part, hospitalization is recommended for patients with acute or life-threatening illness and chronically poisoned requiring dimercaprol therapy. Patients in whom suicidal or homicidal intent is suspected. In patients with acute arsenic poisoning, prognosis may be influenced by unfavorably by rapid institution of dimercaprol therapy. Recovery from arsenical neuropathy appears to be related more to the initial severity of the symptom than to the chelation therapy. Although in patients who do recover, dimercaprol appears to significantly shorten the duration of illness. So this is dimercaprol is again changing in case of arsenic poisoning, right? And after the dimercaprol, we can switch to succimer. Coming to the small topic, that is arsen gas. Arsen is a colorless, non-irritating toxic gas encountered in semiconductor industry or smelting and refining process that is produced when arsenic-containing insecticides are mixed with acids. Arsen gas is highly toxic and extremely flammable. It has garlic or fishy odor, but there may be no odor detectable with toxic exposure. Exposure is by inhalation. Malaise, dizziness, nausea, and abdominal pain within few hours, and intravascular hemolysis and uh, renal failure can develop. And arsen gas